All right, thank you. This is always a fun morning. We try to get through what we think is important in pediatric rheumatology in an hour, and there's some cases at the end, so I'm going to try to keep a steady pace without overdoing it with speed, but so we get through the talk and be able to get to some of the cases. Okay, so the objectives, there are three main disease categories that we're going through, and some of the cases touch on some other conditions in pediatric rheumatology. So the first is juvenile idiopathic arthritis. The most common illness we see in pediatric rheumatology is a chronic disease form. Systemic lupus erythematosus and its manifestations, and then juvenile dermatomyositis. So juvenile idiopathic arthritis, idiopathic, it's not quite clear why it occurs. There's some genetic predisposition and certain environmental factors that aren't quite clear as to what makes people at higher risk. Remember with JIA, there's 7 subgroups, and we'll be going through those in detail. The prevalence is about 1 in 1,500, depending on what prevalence study you look at and what ethnicity. It tends to occur more commonly in of a Caucasian, Northern European population. Classification of JA, of the 7 subtypes, one that's not listed there is other, so you don't have to worry about that so much. If it doesn't fall into the definition of these conditions, then it's considered other. So to start off with JIA, the systemic onset type tends to kind of have its own categories, but in general, if you remember this, you're off to a good start. So the age of onset should be less than 16 years. You should have arthritis, so you make sure it's not just arthralgia, but arthritis. So there's swelling or limitation of motion, often warmth and tenderness. You can just have 2 of those 3 things. But typically, swelling is the key manifestation, pain on motion. Duration greater than 6 weeks, so that's differentiating JIA from reactive arthritis, which is often a more transient, process. And then you exclude other causes for having arthritis. So example, lupus. Patients often have arthritis, so they don't have JIA if they meet definition of lupus, or potentially it's an infection. The examples go on as to the reasons why you might have arthritis. But if you don't have those other causes, you fall into this, I wouldn't call it a wastebasket diagnosis exactly, but you potentially have JIA. So the first question, what type of arthritis is not associated with uveitis or eye inflammation? So systemic onset JIA, there's other forms of JIA, are associated with some form of inflammatory eye disease. And you remember systemic JIA, patients by definition should have arthritis, even though the arthritis may occur later into the disease presentation. And they typically have fever that has a quotidian basis to it, so it's typically more in the evening time. And then the patients, when they're not febrile, often they'll appear well. They have a rash that's evanescent, so it comes and goes. You might see it, and then half hour later might not see it, or it might be in a different place. It typically has a salmon color, and it's migratory. It's moving around. It's more often you see it during fever, and it can occur in places where there's kind of hyperactivity so increased vascular blood flow. So whether where you're lying on warm bed sheets, skin folds, taking a warm bath, Kebner phenomenon on the abdomen, you see the scratching, and you get a secondary GI rash there. Here's another example. So systemic GI can have a monophasic, polyphasic, or chronic course, so it can occur with meeting the definition of systemic GI, and then with time and treatment go away and never come back. It can go away, go into remission, so to speak, and then come back as a polyphasic form or just persist. Other features of systemic JA, just like in the name, it's a systemic illness, so you can have hepatosplenomegaly, lymphadenopathy. Serositis is characteristic, whether it's pleuritis or pericarditis. And like I said, the arthritis can occur after presentations. You can think of systemic features and arthritis, sometimes coming together, and sometimes the arthritis will come on within months of the illness. It's about 10% of JIA cases. It's equal in the genders, whereas the more common forms, oligo and polyarticular JIA, are more common in females. Like the question said, no uveitis. It's not associated with a positive ANA or rheumatoid factor. The blood test ferritin can often be quite elevated. Ferritin can go up as an acute phase reactant, but in systemic J it tends to be quite high, often over 1,000 or a few thousand even if there's an association with what we call macrophage activation syndrome. The next form of JI, oligoarticular, so just like it's in the name, oligo is fewer joints, so you're talking about 4 joints or less at presentation within the first 6 months of disease. It's almost half of JI cases. It's most common in the toddler age group you can see it later on. It typically involves large joints but doesn't fixate at the hips usually. Female to male is more in females, 3 to 1. More commonly the ANA is positive and the rheumatoid factor is negative. So there's a very swollen knee. You're trying to avoid patients getting joint contractures, leg length discrepancy from altered blood flow patterns to the growth plate area on either side of the joint, and associated atrophy of muscles from guarding the joints and not weight bearing appropriately. So uveitis in oligo or polyarticular JIA has a certain characteristic. It's typically anterior, so in the chambers of the eye, there's the anterior, intermediate, and posterior chamber. It's typically anterior, and often the patient doesn't have symptoms, and as a doctor, you can't tell they have it unless they have chronic scarring changes that we're trying to avoid. So this is a very awful-looking deformed pupil with like keratinic precipitates, they call it, and scarring around the pupil. It's more common in oligoarticular JIA to get this. It can be up to 30%, and it's associated with having a positive ANA. I mentioned some of this already, also from uveitis. Iritis and uveitis are kind of interchangeable terms, so not to confuse you. Cataract glaucoma, which can also occur as a side effect of the steroid drops that are often used as one of the treatments. And then without appropriate therapy, you can have significant visual loss in approximately 20% of patients. In terms of the prognosis, if we talk about persistent versus extended disease, so if a patient has less than 5 joints, then they tend to have a better outcome. There's also extended disease, patients that present as an oligoarticular patient after 6 months of disease, then they add on joints, so they're considered oligo and not poly. It's a bit schematic, but polyarticular, so if you have greater than 4 joints, 5 or more in the first 6 months, and then you consider it rheumatoid factor positive or negative. So rheumatoid factor positive occurs in 5% or less of kids that present with JIA. Tends to be teenage, more common girls, and this is really the younger age spectrum of presentation of rheumatoid arthritis, which is more commonly an adult illness. These PIP joints you can see are flexed and look swollen. Some other joint manifestations that can occur in JIA, you can see on this young man, there's retrognathia, so his mandible is recessed, and he's had issues with TMJ arthritis. C-spine involvement, you could imagine him having difficulty extending his neck. Baker's cysts, there's like synovial cysts that typically develop behind the knee in the popliteal area, and they can be sometimes palpated or seen on ultrasound. And then tenosynovial cysts are at the patients get tenosynovitis, so not just synovitis in the joint, but within the tendon sheath of tendons, and then you get these kind of cystic patterns, and the picture is trying to point out sort of the swelling there that's sort of next to the joint of the MCP joints. So polyarticular, remember oligoarticular was close to 50%, polyarticular is close to 30%. Also more common in young patients, but a little bit older. And then there's a bump in the prevalence as well in the teenage years. So that's actually the rheumatoid factor positive patients, but that'll be coming up soon. Constitutional signs are common, so more joints patients tend to have more commonly inflammatory markers like sed rate and CRP, maybe mild anemia of chronic disease, elevated platelets. It's not as a rule, but if they do, there tend to be these constitutional symptoms, low-grade fever, weight loss. And then if they're getting more joints, it's involving other places. So it might be shoulders, hips, jaw, whereas the oligo patients tend to be knee, ankle, wrist a little more. ANA positive 30%, uveitis a little less common than in the oligoarticular patients. The prognosis is worse, so these numbers do tend to change as new studies come out, as the new biologics are being used more and more and FDA approved for arthritis and have been shown to be effective, but typically more joints, more active disease, more poorer prognosis. So like I mentioned, the rheumatoid factor positive patients are the lower age spectrum of rheumatoid arthritis. It tends to involve the symmetrical small joints. So we're talking DIPs, PIPs, MCPs, and MTPs, so a lot of TPs and CPs, but it's the small joints of the fingers, the knuckles, the toes, and symmetric. It certainly can involve other large joints as well, but that's the classic presentation. It tends to be an erosive process, so if left untreated, if you get imaging, you see erosion along the joint line, and people can lose range of motion, and sort of pictures of, or you've probably seen people from other generations more that have been untreated with rheumatoid arthritis, and they get a certain deformity of their hands. The cyclic citrullonated peptide, often abbreviated CCP, is more specific than the rheumatoid factor, but it's not in the polyarticular JIA, rheumatoid factor positive criteria for diagnosing. So by the book, you don't really need to have that, but that potentially could be a test question because it's commonly used clinically. What are manifestations? Patients can get rheumatoid nodules. You can see the nodule right distal to the olecranon there. Potentially have vasculitis, not very common, but you can see that. There's a syndrome called Felty syndrome that involves more systemic features and splenomegaly and neutropenia, uncommon in childhood, but occasionally occurs. The next subset of juvenile idiopathic arthritis is enthesitis-related arthritis. So this is differentiating enthesitis from arthritis. Enthesitis is where tendons insert on bone, and so there's inflammation within the tendon sheath and at that insertion site. And so you, as a clinician, you're differentiating enthesitis from apophysitis. Apophysitis are these common stress-related conditions of age, like Osgood-Schlatter, Sever's disease, whereas this is a true form of autoimmune problem. It's often HLA-B27 associated. Patients that get enthesitis-related arthritis may have inflammatory bowel disease, so that's something to be considered. If it's not been 6 weeks and they have this presentation, they could certainly have reactive arthritis, or what was previously termed Reiter syndrome. This is also the subset of patients that get fit into juvenile ankylosing spondylitis, so it's characteristic as we go through, and I'm just going to put this ahead here, to have sacroiliitis. So sacroiliac tendinitis or inflammatory spinal pain is a feature of enthesitis-related arthritis. So if you have arthritis and enthesitis, you have enthesitis-related arthritis. If you have arthritis or enthesitis, you should have at least two of these things. So I mentioned the sacroiliac aspect, lumbar spine, HLA-B27. Also, if you have a first-degree relative with a confirmed HLA-B27 associated disease. Another aspect is acute anterior iritis. So it's as different than the iritis that the oligoarticular JI patients get that's typically silent and they don't have symptoms. These patients get red, inflamed eyes typically, and you walk in the room, you can often see them, and it's very uncomfortable for them. And now, compared to the other forms of JI, this is more common in males. So a characteristic is arthritis onset and greater than an 8-year-old male. So if I'm able to go back, enthesitis, so this patient's left Achilles tendon, if you compare it to the right, it's much thicker, and there's swelling there. I think that was it. Okay, so reactive arthritis, remember the trigger is often infection. You may not always have infection symptoms, and then you can't really prove that it was infection, but there's these various characteristic examples of patients getting infection and then within weeks getting a reactive arthritis, and the most common are post-dysenteric or genitourinary infections. It's often an asymmetric arthritis, lower extremities, large joints. You can get a feature of scleritis or conjunctivitis, and urethritis would complete that Reiter syndrome triad. In children, that triad is often discontinuous. So you may see the patient in clinic, their eyes beat red, and then they might come back 5 days later and they have a swollen knee. So it doesn't all quite fit completely together. This is another feature of reactive arthritis with potential Reiter syndrome. So Keratoderma blennoragicum. It's a specific skin rash that you can see, and circinate balanitis. So at the head of at the urethral opening, there's erythema there. So it's a good place to check and help you diagnostically. Another form of juvenile idiopathic arthritis, remember there were 7 subtypes and 1 is undifferentiated, so we're getting there. Psoriatic arthritis, so it's very easy diagnosis. If you have a confirmed case of someone with psoriasis and they also have arthritis, you always have to think about what else they could have. A patient can have more than one disease, but that pretty much nails it down. But if you don't have psoriasis and you have certain features of your arthritis disease, you can still be labeled as having psoriatic arthritis. So arthritis with at least 2 of the following. So dactylitis, and I'll have some pictures. So the whole finger is swollen. Sometimes in a slang way, we call that a sausage digit. You can have nail abnormalities, so characteristic pitting of the nails, or onycholysis, or a family history of a first-degree relative with psoriasis. And here are some very swollen toe joints, irritated nails. You can see the shiny nails of the large toe. And those on that left foot, toe 3 and 4, kind of diffusely swollen and not just swollen at the joint. Get a little challenging when the kids are small because their toes are very short. Here's also some example of onycholysis and nail pitting, and you can use the otoscope to help you examine nail pitting. This is a slide that's just showing how there's an inverted pyramid, so to speak. So there tended to be in the past, you start with one drug, maybe Motrin, and then you add another, try some steroids and see if your arthritis gets better. If you really make a diagnosis of juvenile idiopathic arthritis, there tends to be more of a induction period where you're using more medication early, making the patient better, having their disease be inactive, and then taking medication away safely. So it's a little bit different philosophy. In terms of what the drugs are, nonsteroidals are typically not thought to be efficacious in sort of quieting the disease process per se, but can make people feel better. Motrin's more of a PRN drug. If you're doing around the clock, it's more naproxen, for example, which is BID, or meloxicam, which is daily. The category of medications called disease-modifying anti-rheumatic drugs, or DMARDs. So the classic one we use is methotrexate. Also, sulfasalazine is sometimes still used for enthesitis-related arthritis, and patients who can't tolerate methotrexate will use leflunomide, which is a very similar mechanism of action. Steroids still play a role, especially in oligoarticular JI patients or patients with isolated areas of joint arthritis. We'll do selectively interarticular joint injections, and then courses of oral steroids for induction when patients first get diagnosed, and also when they have disease flares. In terms of the biologic medications, the anti-TNF or tumor necrosis factor medications, and they come in various forms these days, are characteristic of use for polyarticular JIA, extended oligo or JIA, so those patients that start with less than 5 joints and then after 6 months extend to have more joints and act like a polyarticular patient. If you're not blocking cytokines specifically, abatacept is a T-cell downregulator that's approved for polyarticular JIA. For systemic JIA, there's IL-1 and IL-6 inhibitor that's used to quiet the systemic manifestations and can have a variable response on the patient's joints. And IL-6 inhibitors are also a second-line treatment for polyarticular JIA. not approved in children are some of the biologics, specifically for psoriasis, for psoriatic arthritis, but we sometimes use them when needed and kind of extrapolate on the adult indication. So in terms of taking care of patients with JIA, from what I've described, you can see there's other disciplines that get involved. So we're working closely with ophthalmologists, at times orthopedists, certainly musculoskeletal radiologists, physical and occupational therapy. Occasionally a patient needs a synovectomy, so a special orthopedic surgeon that does those types of procedures. Rare these days to have patients get joint replacement, but if there's ongoing disease that is really causing disability, occasionally still occurs. And then there's burdens on the family and the child in terms of having this type of chronic illness. And so working with the school and also optimizing nutrition. I think I'm going to take a sip and you guys could take a break. That was the first chunk of the talk. I'll also be here for a little bit afterwards if anybody wants to ask me questions. So systemic lupus erythematosus. So when you think about this illness, it can involve specific features, but in general, it's a multisystemic disease and there's widespread inflammation. So it's inflammation that's involving the blood vessels. It can have features of vasculitis. It's not a primary vasculitis, but it does involve the function of blood vessels and has to do with the endothelium, and as you know, patients with lupus can have predisposition to blood clots and whatnot. It's associated with having autoantibodies, especially the ANA. The ANA, remember, is a screening test. It's one of the classification criteria that I'll go through now, but it's not in and of itself a way of diagnosing. So this is a classification criteria that's typically still used clinically, American College of Rheumatology. You should have, of these 11 criteria bullet points, you should have 4 out of 11 to make a diagnosis of lupus. Occasionally patients have 3 and the 4th is a little bit soft and you know, it's really, what else could they have? And you want to get treatment going, but I typically try to stick with this before jumping the gun. So malar, rash, discoid lesions, photosensitivity, and oral nasal mucocutaneous lesions. I said kind of quickly, but if you notice, they're all skin or mucous membrane issues. So 4 out of 11 have a dermatologic characteristic. I had already mentioned that arthritis can be part of lupus, but it can also affect a lot of other systems. So if you think of a major system, lupus can probably affect it, and it may be on this criteria. So the encephalopathy in the brain, nephritis in the kidney, pleuritis or pericarditis is considered one characteristic. Patients can have cytopenia of any type, so white count, hemoglobin, red blood cells, or platelets. They should have a positive ANA, or depending on what study you read, 1 to 3% of patients will have a negative ANA. So you have to be a little bit careful. And then they often have a positive immunoserology with whether it's anti-double-stranded DNA, anti-Smith antibody, or consistently having positive anti-phospholipid antibodies. So the epidemiology of this is less common than juvenile idiopathic arthritis. It's more common in females. It's happens but not common before puberty. We see it in the puberty years and then women become young adults, and there's a ethnic predisposition, less in Caucasian patients. So pediatric SLE can be variable, so patients can have a subtle disease presentation or it can be very dramatic, and patients can be quite sick. So patients have joint pain more than they have true arthritis. They may have mild fever, muscle aching, hair loss. All those things are often in patients, especially fatigue, but if you notice, they're not a way to diagnose lupus. Fever patients often have a low-grade fever, but it's not part of the disease criteria. Platelets tend to be low, potentially with bruising or bleeding. Hematuria and proteinuria are ways of diagnosing nephritis and nephrosis, also checking the blood pressure, and of course the creatinine. And then the neurologic manifestations of lupus can be widespread, from just like mild depression to everything like transverse myelitis affecting the spinal cord, strokes, seizures. Here's some dramatic rashes of lupus in the malar distribution. So you can see the rash, especially in that girl, sparing the nasal labial fold. So that's characteristic of lupus, and it's also going over the nasal bridge. Discoid lupus, we don't see that that commonly in children, but you can see these kind of round lesions that have a raised appearance on their border. And there's characteristic skin biopsy finding, hyperkeratosis, follicular plugs, atrophic annular lesions. And then there's a dermal band test that involves the immunofluorescence staining that they do on the on the rash. Photosensitivity, you notice this woman's, one of the 4 skin manifestations of lupus was photosensitivity, and this woman's rash is primarily in, we call it a shawl sign, so in the V-neck of her shirt that was exposed to sun. Patients with lupus can have Raynaud's phenomenon. It's not part of the lupus criteria, but we try to distinguish Raynaud's phenomenon versus Raynaud's disease. Raynaud's phenomenon is common in teenage girls. If you see it some with patients on ADHD medication, if it's truly triphasic, going from white to blue and then back to red in an episodic pattern, it's not just associated with cold exposure, then you start looking into whether it's a presentation of mixed connective tissue disease, which can have features of lupus, scleroderma, or even dermatomyositis. So that's when rheumatology can get a little bit confusing. But if you just distinguish Raynaud's phenomena, which is more of a physiologic process versus presentation of disease, that's a good start. Now this is back to lupus, so the mucocutaneous lesions, commonly it's on the palate. So you see this palate, it's all kind of irritated, erythematous, and ulcerated. Patients can have livedo reticularis, so that kind of modeling on the palm that has a vasculitic look to it. In terms of the organ systems of lupus, I mentioned pleuritis and pneumonitis. There's this concept of shrunken lung, so that's like if the blood flow to the lung is not appropriate, the lung can actually have a shrunken appearance. From a cardiac manifestation, there's different things that can happen, but if you focus on, is there pericarditis, is there myocarditis, could there be Lehmann-Sachs endocarditis? Not common, but that tends to affect the mitral valve. And then patients with lupus are predisposed to coronary artery disease, which typically doesn't occur in the childhood age group. Patients with lupus can get autoimmune hepatitis and pancreatitis, not part of the lupus criteria, but certainly occurs. So which of the following findings is not characteristic of lupus? So it was, patients with lupus have cytopenia, so low counts, so they typically have thrombocytopenia. And they can also have anemia, so it's whether it's anemia chronic disease or hemolytic anemia, and it typically is Coombs positive. Leukopenia, by definition, in helping diagnose, should be less than 4,000, and it's often a lymphocytopenia. And then the predisposition to thrombosis typically involves antiphospholipid antibodies that should, if they're positive, they should be rechecked in 3 months, because often there can be a false positive with these tests, and they can be positive after infection or transiently elevated, and typically there's a prolonged PTT. I mentioned the array of things that can happen in the CNS system. Lupus psychosis, migraine headaches, chorea, these are things that I hadn't mentioned. You're trying to balance if a patient already is diagnosed with lupus, if they're on immune suppressant medications or any of these features, infectious, and trying to understand, is it a side effect of the medication? Is it the lupus? Is it something else? So that's the game or balance that we try to strike in rheumatology, of making the right decision and being thorough with what management we do. Nephritis often develops early in the disease, so if you don't see it at presentation, it's not as common that it just comes on. But that being said, we follow urine tests closely and blood pressures to try to evaluate. Lupus nephritis tends to have this immune complex pathogenesis, so patients often have low complement levels, and it's associated with the anti-double-stranded DNA. This is a slide I'm going to keep up just for a little bit longer. It's the WHO classification for lupus nephritis. So there's 6 classifications. The way to make it a little more simple for you is the first one is normal. So if you do a kidney biopsy, say you thought the patient had it and it was completely normal, then they're actually considered class 1. If they're class 6, they have so much scarring that there's typically like an end-stage renal disease. And then 2, 3, 4, and 5 have a very variable degree of pathology. Mesangial is 2, 5 is membranous, so both start with M. Membranous tends to have a lot of protein in the urine, so there's leaking at the basement membrane level and significant proteinuria. And then 3 and 4, you could think of focal is not as bad as diffuse. So, and if you look at the chart, proteinuria, as you go down the numbers, the proteinuria gets worse. So I was mentioning 5 tends to have lots of proteinuria. 4 tends to be the most severe. So I'm jumping around, but if you stick with those points, it's easier to remember than trying to sort of memorize this chart. I think I'm going to skip that. So a few tricks of the trade. Patients with lupus often have an elevated SED rate, but not uncommonly their CRP is normal. Hematologic, all the forms of cytopenia. If you're looking for glomerular renal disease, you're looking for pathologic casts in the urine and for signs of disease activity, or what we call active sediment in the urine. The complements tend to be low. If the complements are elevated, they're acting more as an acute phase reactant. You see that more in infection or other autoimmune conditions that aren't considered immune complex diseases. The ANA, so it's positive in most patients. The titer doesn't tend to correlate with clinical course. It's a little easier with the diagnosis, though, if the patient's titer is quite high compared to borderline normal. And keep in mind that about 25% of people can have a positive ANA, and if it's not, or test isn't ordered for the right clinical reason, you can get thrown around by having these false positive results. So the ANA test is done in different ways. The characteristic way is to have it done by an immune fluorescence assay. So in the lab, they're looking at the antibodies and how they fluoresce and attach to cells, and so they can have a rim pattern, a homogeneous pattern, a speckled pattern, and a nucleolar pattern. Nucleolar tends to be a false positive, but it's also associated with scleroderma. Keeping that in mind, homogeneous and speckled are kind of nonspecific and don't really help that much diagnostically. So the other autoantibodies in lupus, I mentioned double-stranded DNA is associated with renal disease. If you're to order an extractable nuclear antigen panel, or an ENA, it's a panel of autoantibodies that also includes the SSA and SSP, or sometimes called Rho and La. Those are associated with Sjogren's disease, with, of course, are the pathologic antibodies in neonatal lupus, as well as photosensitive or skin-sensitive lupus. Anti-Smith antibody is specific for lupus. Anti-RNP, I had mentioned this disorder, mixed connective tissue disease, which patients often present with Raynaud's, what are called nail-fold capillary changes, which I'll show you in a bit. And they tend to have that antibody. A histone antibody is associated with drug-induced lupus, but about 50% of lupus patients also have that, so you have to be careful in interpreting it. A specific antibody called anti-ribosomal P is associated with lupus psychosis. Patients with lupus not uncommonly have anti-thyroid antibodies. You're on the lookout for thyroid disease. If patients have active lupus, sometimes they have, we call a sick euthyroid syndrome. It affects their thyroid function, but they don't exactly have a chronic autoimmune thyroiditis. I mentioned the lupus anticoagulant. So there's a lupus anticoagulant panel of the specific antiphospholipid antibodies. There's anticardiolipin antibodies and anti-beta-2 glycoprotein antibodies. The anti-beta-2 glycoprotein antibodies are more associated with stroke than the others. The treatment, so you're working with different disciplines as well, like in JIA. Steroids are still a mainstay of treatment, and patients with lupus are often on chronic low-dose steroids. Patients are we sometimes add steroid-sparing agents just because we can't get them off steroids. But in general, you're using other medications in lupus outside of steroids and outside of hydroxychloroquine, which is another name for that is Plaquenil, when you have major, what we think of, important organ involvement. So if you have lupus nephritis, lupus brain disease, lung, heart, you're trying to preserve these organs from being damaged. So you're using more aggressive immune modulation. Cyclophosphamide is a chemotherapeutic drug, is the most potent medication that we use in lupus, and typically is reserved for patients with significant systemic disease, but primarily for specific patterns of lupus nephritis, so that class 4 lupus disease, that WHO classification, brain involvement, significant heart involvement. Mycophenolate mofetil has become a drug that's used potentially in place of cyclophosphamide. It's an oral medication, so you're working with the patient to take their medication at home. Azathioprine is also an alternative, either steroid-sparing agent, often used in that way, or controlling lupus in general, and can have indication potentially for mild renal disease. Aspirin is used if you have these antiphospholipid antibodies and patients had some evidence of clotting already. These are medications that I've talked about some. Hydroxychloroquine, this is a medication that helps prevent disease flare and can help skin lupus. Non-steroidals may help your joint pain, but typically aren't a treatment for lupus. Rituximab, not FDA approved for lupus, but used in indications when there's cytopenia, and so autoimmune hemolytic anemia, and significant thrombocytopenia, so you're preventing the maturation of B cells from being able to make antibody production, and a medication called belimumab, human monoclonal to B cell activating factor, which is actually approved for the treatment of lupus, and its indication tends to be when you can't get a patient off prednisone enough and there's significant risk of side effects from the prednisone. What other therapy do? You prevent sun exposure, especially in patients who are sun sensitive. You watch and manage hypertension if they have renal disease or side effects from the steroids related to that, issues with their lipids. So you're thinking about preventive cardiology, osteoporosis related to and bone health related to the steroids and having chronic inflammation, and then important immunizations like annual influenza and pneumococcal series. Lupus is characterized by exacerbations and remissions, so patients can have dormant periods and then have periods where they have lupus flare. We talked about this. The illness tends to be worse in ethnicities that are not Caucasian, as well as in the male gender. So for some reason, it has to do with pathogenesis and chromosome differences. I touched upon neonatal lupus. Neonatal lupus, remember, is antibodies transmitted from mother to fetus, SSA, SSB. Mom may not even know that she has these antibodies, may not have a diagnosis of Sjogren's disease, and it's found later once the baby is found to have neonatal lupus that the mom's tested, and she may have these antibodies. So the thing that can be real detrimental to the baby is heart block, and this occurs earlier in the pregnancy, and so by the time there's block, it's often non-reversible, potentially is a reason for a baby to need a heart transplant and to use pacers and whatnot. But typically neonatal lupus resolves. So the skin rash, which can be kind of dramatic, as you see on this baby, it tends to resolve 6, 8, 12 weeks into after birth. There's a variable degree of hepatitis. You can have thrombocytopenia. And the treatment tends to be just watch and wait and reassure the mother. Okay, one more break here. All right, our last disease category, and if we can get to the cases, we're doing well. So juvenile dermatomyositis. Look at the name. So skin and muscle with itis on the end, skin muscle inflammation. And it involves inflammation of the skin and striated muscle, and you consider it a blood vessel vasculopathy. So again, different than a classic vasculitis disease. So the criteria for making the diagnosis, you typically focus on proximal muscle weakness, characteristic skin changes, elevation of at least one muscle enzyme. Potentially, if you feel the need to do an EMG, there may be these myopathic changes. If you clinically feel the need to do a muscle biopsy, there can be a characteristic appearance with necrosis. And you should have rash and potentially 3 of these other criteria. Clinically, as we moved ahead in using MRI and gotten more used to how to diagnose juvenile dermatomyositis, there's less muscle biopsies and less EMGs being done, so the classic criteria sort of drift. The mean age is 7 years, so we're talking grade school kids. They can be quite young, 2-3 years old, or present in the teenage years, and female 2 to 1 in prevalence. Onset. So a lot of times this is a condition that kind of sneaks up on parents and children, where slowly they become more dysfunctional, and then it becomes more apparent as to what's going on, having difficulty going upstairs, eventually difficulty getting on the bus, falling periodically, and then as the parents look back, it's been a few months. So there are these constitutional symptoms that can occur as well: malaise, weight loss, fatigue. I talked about the muscle weakness being more proximal. If they have very severe dermatomyositis, there's distal weakness that becomes involved. But we're talking more neck flexors, limb girdle weakness. The Gower sign, remember, is helpful when checking younger kids, because it's difficult to put them through a strength test and feel comfortable that you're getting an accurate assessment. So whether they have a normal Gower and get off the floor, can you get off the floor without using your hands, or they need assistance by pushing up on their knees or pulling up from a chair. They often have muscle pain, so sometimes you can see frank edema, for example, in the legs, but they'll kind of rub their thighs and their arms. The muscle disease can occur on the inside as well. So patients can involve esophageal function. So kids can have reflux. They may present with voice changes related to the reflux. You have to be careful because aspiration can occur if it's bad enough. And to test the esophageal issue, we're doing swallow studies and whatnot. Occasionally, dermatomyositis involves the lung and the heart as well. So which of the following skin findings is specific for juvenile dermatomyositis? All right, so I'm going to move on here. We're going to start to talk about the skin manifestations. So the cutaneous disease, heliotrope, so that's the violaceous discoloration and edema, telangiectasia of the eyelids. So there was that girl who had a lupus rash where it was that prominent malar rash. I should have pointed out, but her eyelids were clear, whereas the dermato patients can get a rash in a malar distribution, but the rash kind of extends up the face. It's on the eyelids, which we call heliotrope. And then the Gauthron's rash, which was the answer in the question, it's over extensor surfaces. So you see the scaly erythematous rash that's over the knuckles, and that's the characteristic place. You also see it on the extensor surfaces of the elbows and the knees, and occasionally even the toes. Photosensitivity can be an issue as well. So that's a picture, of course, of an older woman, but in that shawl-type distribution. It's a vasculopathy, so kids can get ulcers, which can be difficult to heal. And then features of lipodystrophy. So for some reason, the pathogenesis involves fat atrophy, and you can literally get kind of wasting in certain parts of the body. The cutaneous disease, so this is, I mentioned this before, in patients that have Raynaud's disease, if you're looking for pathology, whether it's scleroderma, dermatomyositis, mixed connective tissue disease, those patients will often have abnormal nail-fold capillary exams. So you're using the otoscope. If you're fancy enough in your clinic to have a capillaroscopy camera, then you get a nice, good look, and you can use the gel that they have in clinic to kind of bring out, as the light goes through the gel, there's refraction that can occur. So in my upper left, you can see those are normal nail-fold capillaries, normal little vessels that go to the nail bed, and then there's features in the other 3 pictures of dropout, telangiectasias, thickening, bleeding of the blood vessels, and in that naked view, so to speak, those fingers, you can actually see the abnormalities in the nail fold capillaries. So this is characteristic of patients that have dermatomyositis. Patients with dermatomyositis can have arthritis. Like I mentioned, potentially Raynaud's. Abdominal pain, so this vasculopathy can go to the abdomen, and one of the risks is abdominal perforation, and I mentioned dermatomyositis can involve the heart and potentially the lungs as well. So calcinosis is something that can occur in patients with long-standing dermatomyositis. So there's like all these conditions, there's mild forms and severe forms. The more severe vasculopathy forms that are untreated, there's risk of calcinosis. So this is what we're trying to prevent by treating the patients rather aggressively, besides just getting them walking and having normal strength and not getting ulcers and having normal esophageal function and whatnot, preventing these calcinosis lesions from developing, which can be hard to clear. And you can see on the x-ray here, the calcium comes out. There's typically within fascial planes or in subcutaneous areas, and you can see on that picture. So in the differential, you're thinking about what infections or post-infections can cause a weakness, a certain rash distribution. Patients with calf myalgia, viral type symptoms, the systemic features of strep and staph, trichinosis, toxoplasmosis, polio. Also myopathy, so when the diagnosis isn't clear, we certainly have neurology helping us try to understand if the weakness is coming from another etiology, whether it's considered congenital or metabolic or associated with an endocrine abnormality. Drugs and toxins potentially, so you just take a look, patient for some reason is on a statin. Could there have been some sort of toxic exposure? Heat exhaustion, right, makes people's face flush, they feel weak. The laboratory abnormalities with dermatomyositis, they may not have an elevated SED rate in CRP. The muscle enzymes that we look at are the 4 that I bolded, so those are elevated in other conditions. For, as you know, the AST is elevated in abnormalities with the liver, but it also has a component of being elevated when you have myositis. You could potentially have an immunoglobulin deficiency, and ANA is associated with having dermatomyositis and potentially specific myositis-associated antibodies. If any of those are positive, then it gives you a clue as to whether the patient has a risk for calcinosis, if they have a risk for lung disease, and you should be monitoring their lungs, such and so forth. Here's an MRI with STIR images, which brings out the myositis feature and like muscle edema. And if you get that in a patchy distribution in a proximal location, so this is the proximal thighs, that can help you with a patient and prevent them from getting a biopsy or knowing where to do for the surgeons to do the biopsy. If you do a biopsy, there's characteristic perifascicular inflammation, and you can see those white blood cells that are lodged within the muscle fibrils. And then depending on the stage of the disease, they can have features of regeneration. And I mentioned there's a vasculopathy component to the illness on more that you see more with like an E&M slide. The treatment has its own angle. You see some of these medications that we use with other conditions, steroids, lots of steroids, but we try to limit that. Methotrexate is a mainstay, so we get that on board with almost all patients right off the bat. Hydroxychloroquine for skin disease. IVIG is used for patients with resistant skin disease, potentially muscle disease, in a way to prevent using a lot of steroids. And then secondary therapies, cyclosporin, rituximab has a role as well, and very severe patients, potentially cyclophosphamide. The supportive treatment, being very careful to prevent aspiration, skin care from ulcers, and also as a sun-sensitive condition, preventing a lot of UV exposure. Also, like I mentioned, with systemic JA, it can have a monocyclic, polycyclic, or chronic course. So does it come and go? Does it go away with treatment and then come back later, or is it chronic? Wow, okay. So those are the answers, I guess, if you're looking back at the questions we've had. So we've got 12 more minutes, which I think gives us a good cushion here to go through some questions. So this gives you an overview. We talked about JIA, lupus, dermatomyositis. We talked about Raynaud's, and I was bringing in certain other disorders that come in when you have Raynaud's, differentials with those conditions. But in rheumatology, we also get involved with autoinflammatory syndromes, for which of this list, familial Mediterranean fever, the PFAPA diagnosis, which is the long acronym here, and other autoinflammatory conditions fall into. We take care of patients that have chronic pain that's not thought to be associated from inflammation, but it has its own type of pathogenesis. So whether you call that juvenile fibromyalgia or reflex neurovascular dystrophy, if it appears in a certain fashion. Sarcoidosis, scleroderma, Takayasu arteritis is an example of a large vessel vasculitis. Granulomatosis polyangiitis syndrome, which for the more old school people in the room used to be called Wegener's granulomatosis. So that's one of the ANCA-associated vasculitides, and as well as Churg-Strauss disease, and something called microscopic polyangiitis. Okay, so question number one, 3-year-old male with fever has been seen every 4 weeks for fever for the last 6 months. The fevers come like clockwork, almost monthly. They're associated with a sore throat, swollen glands, and abdominal pain. The fever's to 103 for 4 or 5 days, minimally responsive to Tylenol and Motrin. Between episodes, he's completely healthy. On exam, his growth parameters are normal. He's febrile to almost 40 and looks ill. He has oropharyngeal erythema, tonsillar hypertrophy, posterior pharyngeal ulcers, anterior cervical adenopathy, and abdominal tenderness. What's the most likely finding in this patient? So in a single episode, it almost looks like a virus, right? Adenovirus or strep, but this mother's coming in every month and tells you this occurs in this periodic fashion. So SED rate in CRP was the answer. Which therapeutic option has shown the greatest efficacy in treating this condition? So we haven't told you what the condition is yet, but if you're getting the gist of things. Okay, so this is an example of a patient with PFAPA, so periodic fever, aphthous stomatitis, pharyngitis, and adenopathy syndrome. Of the autoinflammatory diseases, this tends to be the most periodic, so parents can tell you, they can predict when it's happening. It comes like clockwork. The average age of onset, the typical age of onset is about 18 to 24 months, but it can occur a bit earlier or a bit later. It tends to dissipate in patients, so this isn't an illness that people tend to have for life. It tends to go away. We tend to tell patients 7 to 10 years of age, but in reality, it's a bit hard to know. There's a lot of patients we see that don't quite always get mouth sores or don't always quite pharyngitis, but I try to be as strict as I can with the diagnosis. Most patients respond to a single dose of prednisone right at the start of the episode, but if a patient really falls into this disease phenotype, 80 to even 90% of patients will get better with a tonsil and adenoidectomy. So that was the answer to the question. All right, so 16-year-old female presents for evaluation of fatigue. For the last 4 months, she has been experiencing intermittent muscle and joint pain in addition to chronic daily headaches. The pain wakes her from sleep. She often feels tired when she awakes. She has not been to school in 2 weeks and takes a 3-hour nap every day. Her examination is normal except for tenderness over her trapezius, second ribs, medial, tibial tuberosities, and gluteus medius. What is the treatment that's most likely to result in long-term improvement in this patient? So this is a description of a patient with juvenile fibromyalgia. So if you noticed, she's not sleeping well, she feels tired when she wakes up, the places where she has pain are characteristic trigger points. So she's having a lot of muscle spasm. And they can often be associated chronic headaches and chronic abdominal pain. There's various forms of treatment. In the pediatric age group, we typically work with counselors, physical therapists, and do kind of cognitive behavioral therapy approach. Question 4, 15-year-old female presents to your office for evaluation of fatigue, low-grade fevers, headaches, abdominal pain after eating, and pain in the left arm with exercise. Her examination, on exam, she's obese, mildly hypertensive, 132/89, but your nurse also notes a 15-millimeter difference. Difference in systolic blood pressure between the arms. The remainder of your exam is normal. What's the most appropriate next step in your evaluation? Good. So you did well with that. So this is an example of a patient. They have a high suspicion for Takayasu Arteritis. So more common in females. Tends to be younger women. So even in the adult population, it's younger women. We're talking about, so when you think of vasculitis diseases, you can categorize them in your head based on the size of the vessel. So this is an example of the classic large vessel vasculitis. So it involves and it's in a patch. It can be diffuse, but it tends to be an Apache distribution of the aorta, and then potentially of major branch vessels. So if the aorta, as it connects to the renal arteries, the celiac artery, mesenteric arteries, the carotids and whatnot, and then you can get various disease manifestations depending on where the blood vessels are involved. Also, patients often have constitutional symptoms, so fever. It's a classic condition where you have fever of unknown origin, because if you have large vessel involved, you're not getting skin involvement from small vessel disease. You tend to not get renal involvement from small vessel vasculitis. It's involving the large vessel, and so it's important to feel for pulses and to listen for bruits. And if you have enough resources at hand, do what you guys decided to do, was an MRA of the aorta and its large vessels to look for these classic features. Question 5, 8-year-old female is being seen for rash. Her mother noted a linear band of violet skin on the left outer thigh, which has become larger and thicker over the last several months. On exam, there is an 11 centimeter by 3 centimeter plaque with violaceous borders extending from the groin to the knee on the left medial thigh. What information can you offer to this mother about the prognosis for this condition? Okay, so this is an example of localized scleroderma. So the answer was C. The 25% can have extracutaneous manifestations. So this is pretty characteristic of in the pediatric age group. There's different forms of localized scleroderma, so just like it's in the name, it's not affecting the whole body. Occasionally, people have esophageal involvement, autoimmune thyroid disease, arthritis that can go along with it or be associated with it. It can be in a linear pattern. If it crosses the joint line, you have more disability, so then it can affect cause joint contractures. Just depending on how widespread the morphia is, it can cause leg length discrepancy. It can affect breast development if the lesions are in that distribution. There are patches that can be called morphia, so circumscribed morphia. It can have different thickness, and that can affect how severe the manifestation is of the illness as well. There's a condition called eosinophilic fasciitis that gets all the way to the fascia. And then if there's something called Perry-Romberg syndrome, if it involves on the head, it can also affect some of the local brain, and then you can potentially have seizures there. So if you have that, you typically do an MRI and look from that. So localized scleroderma, you get atrophy of the subcutaneous tissues. It literally looks like you have scleroderma, but it's in one patch. And you can see on this patient's left leg, there's kind of a dip in the shin and raise, and it's shiny there. It's not thought to just be the light, but laterally on the skin, there's atrophy. Okay, question 6. We have a little more time. 16-year-old female for an annual checkup who's been cared for by your partner. She has been treated 4 times in the last year for sinusitis and 3 times for culture-negative urinary tract infections. On exam, her blood pressure is mildly elevated at 139/88. Inspection of her nasal mucosa demonstrates very edematous and friable mucosa. Her lungs are clear and she has no pitting edema. Her urinalysis today demonstrates 2 plus blood, 2 plus protein, 1 plus leukocyte esterase. Which of the following of her labs is most likely to be demonstrated? So this one was a little bit harder. This is a classic presentation of granulomatosis polyangiitis syndrome, or what used to be called Wegener's granulomatosis. So it's one we were taught that it was like a pulmonary renal syndrome. So the patient has hypertension, but a part of the pulmonary system in this disease, you could almost think of it as a sinopulmonary. So patients get chronic sinusitis. They can get upper airway lesions with granuloma, and it also can affect the lung and have cystic lung disease. So let's see. So the triad of sinusitis, pulmonary hemorrhage, glomerulonephritis. Patients can be quite sick if they have a degree of pulmonary hemorrhage. They often present with sinusitis or nosebleeds, kind of refractory otitis media, subglottic stenosis, like I mentioned, and if patients may be asymptomatic, so getting a screening ear, nose, and throat upper airway check can be important, and ANCA is the characteristic antibody. And if you have a positive ANCA, Wegener's patients tend to have a C ANCA, and antiproteinase 3 is the specific antibody that's positive in the majority of patients. So here's a chest CT with cystic lung disease that you see some evidence of lung disease on the x-ray, but there's the CT that brings out the pathology better. And we have run out of time, as Dr. Sabella is probably walking up here, but which of the following findings indicate an underlying rheumatologic condition is caused by Raynaud's phenomenon? So that concept of Raynaud's phenomenon compared to Raynaud's disease. There you go. So you're ending on a good note. So if you have a positive ANA and abnormal nail-filled capillaries, that's a sign of Raynaud's pathology. Okay? We pretty much did it. The last question's about sarcoid disease. I'm getting the white towel here. Okay. Good luck to everybody, okay?